Oh no, where's the chat? The chat is not... Where's the chat? Where's the chat? The chat's gone. Wait. Hindi ko kayo kita. Oh god. Okay. Freaking. Oh, there we go. Okay. What the heck, man? The YouTube is weird. YouTube is so weird, man. The chat doesn't load properly. Oh wait, let me unpin this. Okay. So, good evening. Good evening. Fab Master, hello. Archetype, hello. Updog, hello. Manachan, hello. Nimby, hello. I'm not one of you, hello. Ventriloquist dummy, hello. Popular, hello. Bima, good night. Okay, good night. Somnus Lupus, hello. Good evening. Good evening. Wait, what the heck? Okay, there's another thing that's funny. You know what else is funny? The chat is being auto-translated to English on OBS. You guys are being translated to English. Wait, why? Teka lang. Why are you guys being translated to English? You might... Look at this. You guys are being translated to English. Yeah, automatically. Like on the YouTube, on the screen. Okay, on the stream itself, you can see that your chat is in whatever language you're speaking, right? But then on OBS, when I'm reading your chat on OBS, it's being translated to English in real time. Look at this, it's so weird. It's so weird. It's so weird. Look at this. To be fair, the translations are quite accurate. Kinda accurate. I mean, if I read the chat, it's actually almost the same as what you guys are saying in Filipino. So you guys are actually still making sense to me. This is interesting. Look at this. Oh, if I hover my mouse on the chat, on let's say Manachan, this is what your chat says, okay? Is it really so he can translate everything into English? And then when I hover it, talaga ba kaya niya i-translate sa English lahat? You guys are being translated to English. Hey, limit test the translator. Uy, limit test yung See, you guys are being translated. Yeah. This is actually... How do I turn this off? Wait, how do I turn this off? I want to read you guys in like in the pure Filipino language. Disturbing. Nakakapagpagab putang ina. Basta! Yan! O, diba? OBS has sent us a translation. Pinasalin tayo ng OBS. Okay, that one was wrong, but it is almost the same. Okay. You guys are being translated to English and I don't know how to change it, bro. How do I change this? Gago, para palitan to. Okay, guys. Paano to? How do I, how do I turn this off? I can't. Pati yung ha-ha-ha nyo na translate, naging ha-ha-ha pa rin. Pati yung ha-ha-ha, yung capitalized ha-ha-ha na translate din, pero naging ha-ha-ha din. Alam mo yung, pag may nag-chat ng ha 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 in all caps, alam mong Pinoy yun. Pati yan tinranslate eh. Okay, I don't know how to I don't know how to fix this. So yeah, when I read your chat, when I read your chat on OBS, I'm gonna be seeing it in English. I'm gonna be seeing it in English, and the translation is actually pretty accurate. It's not 100% accurate, maybe around 90% accurate, because I can understand what you guys are saying. It's not like super broken. Oh, except this one. Somnus Lupus says, Gagi, ginawa kaming konyo ng OBS. That was translated to OBS made us a connoisseur. I was like, what is this? And then, okay. Okay, guys, wait. All right. I don't know how to fix this. I don't know why you guys are being auto-translate. Is it like this on YouTube also? Let me go to YouTube. I'm gonna go straight to YouTube and look at the stream from there. I'm gonna look at the chat straight from YouTube. And I wanna see if it's also like that. Hold on, I'm gonna take a look right now. Ito, let me look at this right. May ad pa. Ka-ad pa. Okay, on YouTube. Oh, even on YouTube, yeah, you guys are being translated. How do I turn this off? How do I turn this off, bro? Do I have a mod on here? May mod ba ako dito? Paano naman, no? Let's not become slaves to the English. Wag tayo magpaalipin sa mga English. We need to love our language. You guys are being translated, and I don't know how to change this. I don't know. No, it's happening on YouTube, not just OBS. It's on YouTube. I don't know how to change this. Wait. Okay, I'm gonna search this. How to turn off auto translate chat YouTube. Okay, you can turn off YouTube. Okay, inside the chat, the globe icon inside it. I don't see the what? What are you talking about? Wait. Oh, here it is. Wait. Unless I wonder if this is some kind of beta test by YouTube or something. Is this a freaking beta test? Okay, the gear? I don't see that. Where the gear? Oh, I have to go to... Okay. Yeah. I don't understand. Wait. Okay, let me go to the live. Inang to. Sana yan. I need to stop this, bro. Oh, here it is. Is this the one? No, it's not. How do I? YouTube is taking ShioriPon's job. Go ShioriPon, get your job back. See, look at this. I'm reading the chat. It's in English, but I know you guys are speaking Tagalog. I know you guys are speaking Tagalog because there's like a translation logo right beside it. And okay, this is useful if I have like a chat that's full of like people from outside the Philippines that don't speak English. But you guys are, I don't know what to do here. How do you do this? Okay, ito. How do I freaking? Ito? What's up, Mandi? Teka lang, I don't know how to. Where do I freaking go? Ito ba? Oh, ito. I think it's here. Okay, it's supposed to be it. Okay. Where's the thing? Hindi ko mahanap! Asan na yung... Ito. Ano ba yun? Wait, I don't know how to. Yeah, if someone types in Japanese, yeah, it will be. It will be. Hold on. Gago, hindi ko ma-off. I don't know how to turn this off. Wait. To turn off automatic chapters and tap settings. I don't see this. This feature is currently available for mobile live streams only. Are you kidding me? Mobile? Eh, nasa PC ako. It's only on mobile? So I can't turn it. Wala, I can't turn it off, guys. You guys are gonna be in English to me. You guys are not Filipino to me anymore. You guys are English. Mga Inglesero at Inglesera na kayo sa akin. Wait. Stream settings. Okay, video edit. Live chat. Okay, wait. I think I found it. Manage. Ay, puta ka na. Wait. My gosh. Teka. Stream settings tab. Ito ba? Hindi. Control. Stream settings. Here it is. Where is it? Auto transfer. Wala naman eh. Stream settings, here we go. Wala! There's no option to... What? Wait. Edit customization? Ito? Oh, there it is! Live chat turn off. There it is. Okay, I got it. Okay, chat, start talking. Start speaking. Start chatting in Tagalog. Mag-Tagalog na kayong lahat. Mag-Tagalog na! I think I got it. Sige, mag-chat nga kayo. Tingnan natin kung magta-translate. Let me see. Alright, there we go! Yay! Okay, you guys, okay. So that means you guys couldn't see each other speaking in English, huh? When you guys were chatting, it was in Tagalog, right? It was only on my end where the chat was translated. Yeah? On your end, it wasn't translated? Like, Taglish kami. Okay. Alright, so it was only on my end. Okay, you know, that would be useful if my chat is full of, like, I don't know, Japanese people or whatever, people who are speaking a different language. Okay. Alright. Okay, guys, so we are going to be playing, well, not really play, it's more of, ano to? We're going to be not really playing, but more of doing this is a quiz. Chill. We're gonna chill right now. Let's see. YouTube. Teka. Okay. Teka lang, guys, ha? YouTube. Alright, there we go. Okay! Ay, wala nga no. We should have a... There we go. Okay! We're going to be, we're gonna be answering some cases or try to do some, medical cases here. Okay. Also, by the way, guys, before I start, by the way, I want to say thank you to the ones who donated to my Pixel account because we actually reached the goal. We reached the goal of 10,000 Philippine pesos, 10,000 pesos for patient funds. Patient funds. Thank you so much for those who donated. Thank you so much. This is actually the first time I have. Look, you can see it over here, right? The little bar at the middle of the screen at the bottom. We reached 10,000 plus pesos. So we reached the goal. That is the first goal I've had on what's this? Dono goal I had on Pixel. Thank you so much. Thank you. My patients will be forever grateful. I'll be using that money. I will put them aside, and they will be used for patients who might need them. If they need a certain like materials for their procedure. If they need a medicine that they can't afford, it will be used for them. So this is gonna be put aside. I have like a separate account, like a separate wallet or a separate bank account just for that. Digital bank account just for that, just for that. So thank you so much. Congrats. Yes. It says, Doc, question before sana mag-start. How long did it take you to get comfy sa pag-content create? Speaking sa monitor na walang sumasagot. Oh, that took me a while. That took me a while. It was like the very first time I streamed. The very first stream I did was I was playing Final Fantasy VII Remake, the demo on PlayStation 4, which was That was around late 2019. That was supposed to be a test stream. I think I played that for like an hour or 30 minutes. It was a test stream. So that time it was on the PS4. So malamang walang camera yun. But I can see the chat. And I just streamed quietly. Sometimes I would speak because, I researched on how to stream. I researched on how to stream, and then they would, they would say, try not to leave any dead air, blah, blah, blah. And it was actually hard. It was so awkward, because I'm like, there's no one here. When I started streaming on Twitch, like, with my laptop and everything, it was also kind of hard, because I felt really awkward. Like, my first few streams, maybe for that month of March, I was very it was March 2020 when I started, like around the time COVID started. I was very awkward and very shy, like really awkward and shy, because actually my default, my real self is really, really shy. I'm very shy in real life. So when I started streaming, I was actually very shy. Even if there was no one in the chat that time, I still felt so weird trying to talk to like nobody. And when someone did enter the stream, I'd be like, "Oh, hi." Hi. And then that's it. I don't know what to say. Anyway, yeah, it takes a while. It'll take a while. Like I expect like the first few streams, the first month of streaming or content creating, it'll take a while. It will feel really weird talking to nobody. It'll feel really weird talking to nobody. So one of the first things I did is I don't look at the number of viewers. That's why every time I stream, I try not to look at the number of viewers I have, because it's just gonna be one, which is myself. And I just like play and pretend that I'm talking to somebody. That's it. And then eventually I just got used to it, and eventually you just get used to it. Alright. Dok, kailangan natin pasalamatan ang ating sponsor na Diabetes at Robitussin. Okay, anyway, so, right now, we are in this webpage called Prognosis Your Diagnosis. This is actually an app. This was an app. They have this on iOS and Android. It's just called Prognosis Diagnosis. So if you're a med student or if you're in a medical field, you can try this out. And they have a series of cases here. They have a lot, actually. Like, they got 19 pages. They have 547 cases, okay? So some of them are even divided per specialty. So we have here internal medicine, there's psychiatry, pediatrics. But since I am a surgeon, I wonder if can we organize this into surgery? Oh, here we go, there we go. We can. Ayo! Alright. General surgery, 66 scenarios. Sige, let's try, let's go. There, oi! What is this? Antonio 2. Under control. This looks like a freaking episode. What is this? Antonio 2. Under control. Where's Antonio 1? Wait. We gotta look for Antonio 1. Bro? Asan si Antonio 1? Wait, what is Antonio? Can I search? Antonio. Let's look for Antonio. Oh, it's a case of pheochromocytoma. That is hard. That's actually hard. Wait, why is this like 2025 and this is 2024? What? Did they time travel? Oh, update. I think it's an update. Pheochromocytoma. That is hard. That is very rare for me to find here in the Philippines. Let's look for something a little... I know. Let's look for something else. Some of these are locked. Why are these locked, though? There's a lot of them that's locked. What? Is this paywall? Loaded. Want to continue playing? Start your 7-day. Oh god, yeah, it's a pay. They put it under a paywall. Are you kidding me? Okay, we're gonna go for the free ones. How do you? Can I? Ano? Gagi, may paywall na. Dati walang paywall yun ah. All right. Okay, let's go for bilateral. All right. Alright! What's this? A 50-year-old woman presents with eczema and itching of both nipples for 4 months. Oh. No other symptoms are present. Her medical, surgical, and family histories are unremarkable. She is not on any medications or supplements. Her menarche was at 12 years of age and menopause was at 44 years of age. She has never been pregnant. She has never smoked and drinks socially. Huh. So I'm guessing, okay, 50-year-old woman, nipples for 4. I'm guessing, so this is a breast case. This is definitely a breast case. She has no history of breast cancer though. Menarche. Okay, menarche. I think this is pronounced menarche. Is like the first time. Menarche is the first time a woman menstruates in her life. Menopause is the last time a woman, last time, like the last time they menstruated. Okay, she's never been pregnant. Okay, so she's nully gravid. All right, here we go. Physical examination. Bilateral breasts. Moderate eczema of both nipples, no nipple ulceration, retraction or inversion, no nipple discharge, no breast mass, or axillary lymphadenopathy, no abnormalities, everything. Oh, so she just has like weird ass skin. Okay, so she has itchy skin, itchy nipples. I think this is Paget's disease. This is Paget's disease. Paget's disease of the nipple, man. This is Paget's disease of the nipple. This is how they present. They present with like an itchy, flaky nipple. Sometimes there's no mass, or minsan walang bukol. Sometimes there's none. But since it's a breast, let's see what we have. So yeah, she just has like eczema or like skin problems on the nipples. No masses, so no lumps felt. Axillary lymphadenopathy, so wala no palpable lymph nodes on her armpits, on her axilla. So okay. Okay, okay, what do we do? Alright, here we go. She is 55. She's 58. She's 50. We do a mammogram. We're gonna do a mammogram. Oh! The mammograms of both breasts appear normal with no evidence of masses or microcalcification. Oh, so... Okay. Follow-up ultrasound only shows non-specific skin thickening in the nipple areolar regions of both breasts. There's no... Oh! Okay. So no masses. Okay. Oh, nipple scrape cytology. Okay. Yeah, we do this. We get a sample of the nipple. Oh, see, I was right. Paget cells. It is. I was right. She's got Paget's disease of the nipple, yo. Paget's disease of the nipple. I was right. Okay. Do I need to do anything else? Wedge biopsy? Wait, do I need to do a wedge biopsy? MRI. Oh, wait. Yeah, we should do MRI because... Walang nakita. MRI. Yeah, there we go. Contrast-enhanced MRI demonstrates linear clumped enhancement of both nipples extending to the subareolar space. Indicative of... Oh, she also has DCIS. Ah. Hello, Nichimiya. Hello. Baliktad na pala ngayon yung prof na nagki-quiz, no? Yeah, you see, I'm taking the quiz, but then the next ones are yours. You guys are gonna be ones answering. What is wedge biopsy? I've never heard of wedge biopsy of the breast. Is this like an excision biopsy? But why wedge biopsies? Isn't it supposed to be like a core needle biopsy or some shit? No, wait. No, yeah, we can do a excision biopsy. Do I need to do a wedge biopsy, bro? Okay, yeah, that's okay. Oh, here we go. Microscopic. It's weird that they call it wedge biopsy. I don't know what a wedge biopsy of the breast is. We usually, for like breast mass, we do excision biopsy. Microscopic examination of the biopsy specimen shows infiltration of the epidermis with numerous Paget cells. Underlying low-grade ductal carcinoma in situ. Okay. Alright. Oh! Okay. Oh, what we're gonna do. Alright. So since it's we're gonna do a... Here we go. Bilateral central lobectomy. Yes. Neoadjuvant. She doesn't need neoadjuvant. You know. Alright, let's see how I did. 100%, yo, I am a true surgeon. I am a true surgeon, guys. Yo! I was right. My studying helped. I didn't know what the freak a wedge biopsy was. What's this? Oh, bioanalysis, you can see what... Oh. She's a surgeon. Yes, I am a surgeon. I am a surgeon. Oh, they even give you a freaking... Oh, look at this. Hey, yo! Let's see. This 50-year-old woman has presented with eczema and itching of both nipples. No other signs or symptoms are present. Bilateral eczematous changes of the nipples are most often due to an inflammatory dermopathy. Atopic or contact dermatitis. Malignancies such as Paget's disease of the breast can mimic this appearance but are rarely bilateral. Yeah, actually they are rarely. It's kind of weird that she presented with both nipples having Paget's disease. Breast examination shows no untoward findings, making benign etiology even more likely. However, to be comprehensive and to give the patient peace of mind, it is rational to request a cytological analysis of nipple scrapings. A test that is simple, non-invasive, and inexpensive. Doing so turns out to be an excellent decision as this reveals numerous Paget cells. So yeah, Paget's disease of the breast. Imaging studies are essential next step, given her age and postmenopausal state. Mammogram, yeah, which is the first thing I did was a mammogram. However, this turns out to be normal, yeah. Mammography is negative. You do an ultrasound, which is nothing. That's why you did an MRI, because there was nothing seen. And then that's when we saw a DCIS, ductal carcinoma in situ. Okay, wedge biopsy. I'm guessing if it's Paget's, you do a wedge biopsy. Because, Paget's disease of the breast is something I personally have not seen in my surgery life. I haven't had a patient that has Paget's disease, so I only read this. I only read about this, but I've never actually had a patient with this. Generally include both epidermal and ductal tissue to confirm this with respect to staging as per the tumor node metastasis. Her disease is TIS-NOMO. So yeah, stage 0. She's a DCIS. Okay. Mastectomy was long considered treatment of choice for Paget's disease of the breast. You can do a central lobectomy. yeah, okay. Neoadjuvant chemotherapy is not indicated. Yep. Oh, topical corticosteroids is for eczema or psoriasis. Yeah, which is, wala naman din siyang tuberculosis. They even give ano, ah. This is, whoa. It is complete. I wonder if this is like updated up to like, oh hey, look, take-home messages. Paget's disease of the breast should be considered in the differential diagnosis of eczematous changes of the nipple. Most cases are in postmenopausal women. However, Paget's disease is encountered at all ages, even in men. Okay, boys, even you can get Paget's disease of the nipple. Guys, chat. Even you can get Paget's disease of the nipple. Okay? Pati kayo! Pati kayo, chat, ha? Alright. The mammography and ultrasound have relatively low sensitivity. MRI may be required. Mastectomy has been... Yeah, you just do a lumpectomy, just local excision. Okay. Alright, next! Let's go to the next case. Bro, maybe I should do this, right? 7-day free trial and then I'll just end my subscription after. End the subscription after that. We'll see though. Let's see, okay. Blocked. What's this one? Ooh, okay. We got to the next one. A 64-year-old man presents with vomiting and colicky abdominal pain for 12 hours. His last bowel movement was 10 hours ago. So, 12 hours he's been vomiting and having abdominal pain. Tapos yung huling pain niya 10 hours ago. Normally, he has 2 to 3 bowel movements daily. He has no other symptoms. He also reports intermittent episodes of abdominal pain for the last week that spontaneously subsided. There is no history of abdominal trauma. His medical and surgical histories are unremarkable. He is not on any medications, including over-the-counter drugs or supplements. He drinks socially between 3 to 4 standard drinks per week on average. He does not smoke or use recreational drugs. A full blood count, serum electrolyte assay, liver profile, renal profile, and serum amylase lipase levels are all normal. Okay, so history of the patient. He's a 64-year-old, so senior. Vomiting with abdominal pain for 12 hours. Last bowel movement was 10 hours ago. Normally, he would poop 2 to 3 times a day. No other symptom. Wait, they didn't... Hindi sinabi kung umuutot to, no? They just said he had wala siyang utot. He has never... He had intermittent episodes of abdominal pain for the last week, okay? No history of abdominal trauma. So, hindi siya natamaan sa tiyan. He never had any surgeries. Wala siyang ibang sakit. Wala siyang maintenance. He drinks socially 3 to 4 standard drinks per week on average. Okay, and everything is normal. Okay, let's see. Physical examination. Okay, abdomen is distended. So, lobo yung abdomen niya. There is pain, but no signs of peritonism, so it's not tender. Hyperresonant, exaggerated bowel sounds. He has no hernia. Digital rectal exam, no rectal mass. So no masses or no blood. Okay. Afebrile, so he has no fever. He has dry mucous membranes. Okay, that means he's dehydrated. He's dehydrated, guys. Kinda. Pulse rate is 90. Huh. Okay. 90. BP is okay. So he's still kinda stable. So, if I'm gonna... Okay, okay, based on this case, I am thinking of partial bowel obstruction, probably secondary to a colonic mass. He probably has a colonic mass. Let's see, what else? What else? Wait, he has been vomiting as well. So it can be partial bowel obstruction, probably secondary to a colonic mass. What else? Yeah, that's my number one. That's my number one. Maybe it can be a gastric mass, but then gastric mass. Yeah, it can be a gastric mass. It can be basta ang ano is obstruction. But it's only partial, I think, because I don't think he's completely obstructed yet. Not yet, anyway, but it can turn into that. Heart, lungs, okay, let's continue. Let's see what labs we can request. Wait, his blood tests are okay, though. Look at this. So he's not toxic. X-ray CT... Oh! Okay. Alright. So, in the Philippines, we do an X-ray. There we go. There are multiple dilated loops of small bowel, more than 3 cm with air fluid. Aha, there we go. Forming a step ladder pattern. There is no air under the diaphragm. Okay, so he does have obstruction. His small intestines are dilated. They should have like a photo of this. His small intestines are dilated more than 3 centimeters. That means that there's an obstruction going on. And since it's on the small bowel, that means if he probably has a mass on either on the ileocecal area, the junction between the small intestine and the large intestine, or in the cecum, or in the right side of the colon. Would you obstruction also? Yes, that's actually why I considered obstruction, because if you look at his case, like, he just suddenly unable to, well, not really suddenly, he's been having on and off abdominal pain for a past week, and then 12 hours prior, he's just started vomiting and, having pain, and then he's unable to defecate, unable to poop. Those are like, those symptoms, or those, signs, they point to an obstruction. Especially when you do a physical exam, those symptoms point to an obstruction, and then the physical exam where he has a distended abdomen, so basically lobo yung tiyan niya. See, and hyperresonant, meaning when you listen to the abdomen using the stethoscope, you can hear no, not listen. I mean, if you if you percuss the abdomen, it's like there's a lot of air in there. And then exaggerated bowel sounds, so it's like hyperactive. It's noisy. Okay, so since we have an X-ray, we're gonna do a CT scan. He's stable, so we can do a CT scan. Ha! I was right, yo. Look at this. There's our multiple dilated loops of small bowel with the point of obstruction in the distal ileum. So it's wait. Minimal pneumobilia is present. Oh no, it's not a tumor. It's not a tumor, guys, but the obstruction is, as I suspected, in like the last part of the small intestine. It was either in the ileocecal valve. I was thinking, like the last part. The ileum is the last part of the small intestine, and then cecum is the first part of the large intestine. So the obstruction is in the last part of the small intestine. And he has minimal pneumobilia, meaning he has air in his bile ducts. That means, I think this is, he has a stone. He has a gallstone in his ileum, causing the obstruction. Gallstone ileus. This is gallstone ileus. I guess we wait. So okay. So if it's What is gallstone ileus? Do I need to know an EGD for this? I'm thinking this is... Wait, a colonoscopy goes all the way to the terminal. Okay, I think we should do a colonoscopy. Yeah, colonoscopy tayo, I think. If I remember correctly, colonoscopy reaches the terminal ileum. Am I right? Do they go all the way to the terminal ileum? Or do they only stop at the cecum? I don't remember. No, because I'm thinking which would be the best one. Okay, I think we'll do a colonoscopy just to be sure. He's also 64 years old, so we can do a colonoscopy. Oh, you realize that colonoscopy is not indicated. Okay. So do I not need to do an esophagus? This is until the duodenum, so... Alright, we'll skip this. I don't think we need to do anything there. Identify action. Oh yeah, and nasogastric tube. So put an NGT tube. Yeah, we do. We need to relieve that obstruction. One stage cholecystectomy. Enterolithotomy. Endoscopic retrograde cholangiopancreatitis. Oh wait, I think I read this one. You know what? Gallstone ileus, this is another case that I have not had in real life. I have not had a gallstone ileus case before. I've only read about this. But I've never actually had a case of gallstone ileus before. Like, I've never seen it. This is like... Yeah, he has a stone in the intestinal area. The stone came from the gallbladder. So basically what happened is the stone was so big, it eroded through his gallbladder and entered the intestine and then just went all the way down. It's like really big. So yeah, that's what happened. So if I remember correctly, I think I've never seen this case. So yeah, we have to decompress his bowels by inserting a NGT and enterolithotomy. Yeah, I think we have to remove that stone. It's causing an obstruction, so we gotta remove that. Now, cholecystectomy. This I am not so sure if we do this in the same setting. Like, I don't know if we're supposed to do this at the same time. I think the cholecystectomy is done another time. ERCP. Do we need to do an ERCP? I don't think we need... Do we need to do an ERCP here? Probably not, right? This one's hard. This is actually hard. I've never seen this before. This is worse than a Paget's disease. I even got this... I think I got this one wrong, so... I'm not supposed to do a colonoscopy. But yeah, we definitely do an enterolithotomy. I think that's it. Okay, let's see. I think I did poorly here. Okay, let's see. I think... Evaluate. Oh, 75! I did... Okay, that was okay. That wasn't bad. That wasn't bad. Only a few go 100%. Where did I go wrong? Yeah, here we go. I chose colonoscopy. Oh, you do a cholecystectomy. Oh, I see. Okay. You do it in the same... okay, you do it in the same surgery. Alright. I was thinking you have to do it on a separate surgery. I guess you do it in the same surgery. Alright, let's see the explanations here. Okay, elderly man has presented with colicky, abdominal pain, vomiting, and a reduction in bowel movements. Examination reveals abdominal distension, hyperresonance, and exaggerated bowel sounds. So, this is a case of acute bowel obstruction until proven out otherwise. So, X-ray, yeah, we did that. Small bowel obstruction can be due to either mechanical or functional causes. Mechanical causes can be further subdivided into intraluminal, transmural, and extrinsic causes. Examples of each include foreign bodies, tumors, and adhesions, which are the most common cause of mechanical obstruction. Functional causes include paralytic ileus due to electrolyte or metabolic imbalances or inflammation of the surrounding viscera. Yeah, that's why his labs were all normal. Alright. Hyperacute bowel cells favor mechanical obstruction. The normal serum electrolytes and serum amylase and lipase point against a functional cause. CT scan should follow to help determine the likely etiology, establish the level of obstruction, and detect if intestinal ischemia, necrosis, or perforation is present. So here we saw the zone of transition in the distal ileum along with pneumobilia, air in the biliary tree. So pneumobilia occurs when a fistula forms between the gastrointestinal tract and the gallbladder. This is most often a sequel of chronic or recurrent cholecystitis. Gallstone ileus is a known complication of fistula formation. In this, the gallstone moves through the intestine and may end up in a part of the intestine with the narrowest lumen, the ileum, blocking it. So yeah, that's exactly what I said a while ago. Gallstone ileus is when you have a large ass stone from your gallbladder and it erodes into your intestine and then it just goes down there and then causes obstruction later on. It's something I've never seen in real life, but I've read about it. It's a case that is asked a lot, but you don't really see it, something like that. Presence of pneumobilia and mechanical bowel obstruction satisfy two components of the Wrigler's triad, which is sufficient to diagnose gallstone ileus. EGD should be avoided, yeah, because of the intestinal obstruction. Neither just okay, you don't need to do... okay, so colonoscopy is just up to the cecum. I thought it goes up to the terminal ileum. Alright. Oh, okay, here it is. Since it is a low-risk patient, one-stage cholecystectomy. Oh, okay, so you don't do a cholecystectomy if it's a patient that is not stable. Okay, I understand now. Alright. Oh, there's even a discussion. Gallstone ileus is not a true ileus, but rather a mechanical obstruction that occurs when large gallstone, usually 2.5 centimeters in diameter, erodes into the intestinal lumen through a cholecystenteric fistula, giving rise to mechanical obstruction. Oh look, see, gallstone ileus accounts for 1 to 4 episodes of mechanical bowel obstruction. So yes, it is rare. Mana-chan, 1 to 4% of obstructions, of mechanical bowel obstructions, is caused by gallstone ileus. Morbidity and mortality are both high. Uh-huh. So guys, chat, if you have gallstones, wag mong paabutin. Wag kayong maging 1 to 4% sa mga nagbabara ang bituka. If you have gallstones, get that shit out of there. Look for a surgeon, get it up. Get the surgery. Because a lot of shit can happen if you don't have your gallstone, if you don't have your gallbladder removed due to gallstones, okay? Sometimes I would say, sometimes the most common would be like if the stone falls into the bile duct and then you turn yellow. This one is a rarer complication, and it's worse because it erodes into your intestine and you don't want that, okay? You don't want that. Look at this. Stones 5 centimeters are more likely to become impacted, bro. Why would you even let your stone grow to 5 centimeters? That is so large. Key principles of the management includes resuscitation, correction of okay, blah blah blah. Ooh. Oh, here we go. This is the one. One-stage enterolithotomy, cholecystectomy, and bilioenteric fistula closure is preferred in low-risk patients as it reduces recurrence, prevents malabsorption from a persistent biliary enteric fistula, and prevents cholecystitis, cholangitis, and gallbladder carcinoma. However, it comes with a higher surgical risk, and therefore simple enterolithotomy is often preferred in emergency settings. Okay, there we go. If it's an emergency, you just remove the stone and get out. However, factors such as the available expertise, unit policy, and patient status will influence this choice. Alright. Okay, I did okay. 75, not bad, not bad. Alright, next case, guys. Ipatawas ko lang yan, Doc, may mangkepwang. Alright, what's this one? Concealed. What is this one? Let's see what this one is. Alright, next case. Chat, next case. A 42-year-old woman presents with oligomenorrhea for 2 years. Oh. She has gained 30 kilograms of weight during the same time period, even though her diet remained unchanged. Oh. Her medical history is significant for type 2 diabetes, mellitus, hypertension, and dyslipidemia for 3 years. While well controlled initially, these worsened over the last year. She is currently on metformin, glycoside, telmisartan, and rosuvastatin. Rosuvastatin. In the Philippines, we call it rosuvastatin. But in I think in America, this is called rosuvastatin. Rosuvastatin. I think that's how it's pronounced. I'm not sure. Rosuvastatin. I don't know. I think the stress is on statins. Her family history is significant for polycystic ovarian disease in an older sister. By the way, guys, polycystic ovarian syndrome has officially changed its name from PCOS to PMOS, which is PMOS yun eh, PMOS na, PMOS. It is now polyendocrine metabolic ovarian syndrome. So this is like an official change, guys. PCOS is not PCOS anymore. They call it PMOS, polyendocrine metabolic ovarian syndrome. Okay, she drinks 1 to 2 standard drinks per week socially. She does not smoke. A full blood count is within normal parameters, as are serum electrolyte levels and renal and liver profiles. A thyroid profile and serum FSH, LH, testosterone, prolactin are also normal. Oh, really? The thyroid's normal? Wait? Okay. Bro, this is a hormonal... This is a metabolic disease. Okay. She is a febrile, not pale, nor ecteric, no facial... Okay, she has nothing... Wow, her BMI is 38. She is, I think 38 is obese. She has hypertension. Jesus. Okay. This is a metabolic disease, yo. But her thyroid function test is fine. And her thyroid is okay. FSH and LH are also okay. So that's in the ovaries. So that's her reproductive system. Prolactin, testosterone, and growth hormone. So basically her thyroid is okay and her ovaries are okay. So what else is causing the problem here? She has diabetes. Okay, let's see what the choice is for. Oh, yo. What organ? I'm thinking... hmm... 1 milligram overnight dexamethasone suppression test. Urinary free cortisol. Is this an adrenal case? Oh my god, adrenals. Adrenals are something I can't... Adrenals are something I have not run into like adrenal cases in in my surgical career. I have not. It's either I think this is an adrenal case, bro. I have not run into an adrenal case in real life, bro. I have not run into an adrenal case before. Like, this is so rare for me to see. I haven't even seen one at all. Cushing. Yeah, I think it is Cushing syndrome. I think it's Cushing syndrome. This is okay. Shoot, I don't know how to deal with Cushing. How to deal with adrenals. Okay. Since it's adrenals, I'm guessing. Should we have an imaging for the if there's an adrenal mass? But then again, I don't think it's an adrenal mass. Hyperactive adrenals. Okay. Adrenals would have... Alright, let's see. Oh my god, I do not deal with adrenals, yo. Alright, let's... Cortisol, I guess. Let's check out cortisol. Here we go. 24-hour urinary free cortisol. 210. Okay, a repeat test is performed and the new value is 180. Okay, I'm guessing this is the normal. Yeah, I did the 24. I chose it. It's within normal. Tama ba? 55 to 250 is the normal. Okay. Alright, and then should I check if there's like a mass in her adrenals? Is this better seen on a... I'm gonna go for MRI. Okay, let's go for MRI. MRI! Oh, here we go! MRI scan reveals a hypodense homogeneous mass. Oh, that's 5.1 by 3.7 centimeters in size, located in the superior aspect of the... Oh, it is an adrenal mass! 5? That's pretty big, isn't it? That's like a little cap on top of... That's like a little hat on top of her left kidney, yo. Left, I'm on my left. Yeah, left kidney. Left. Ugh. Unlucky. Yeah, it is big. It's freaking 5 cm. That's like a giant gallstone, but it's the adrenals. Heck. Okay, I think I'm gonna do badly here because I don't really see adrenal masses. I have not really I don't see adrenal masses that much, or adrenal cases much. Pheochromocytoma, you think? Alright, what else do we need? I think we already know that it's this. Do we need to, is this okay? Early morning ACTH. we already established that she has an adrenal shit going on. I think we're okay with that, yeah? Is there anything else we need to test? Alright, let's continue. Since I'm a surgeon, I'm gonna go laparoscopic adrenalectomy. Gotta go back. Somatostatin. Surgery is the way. Yeah, surgery is the way. What do you mean, yo? I'm a surgeon. We found what's causing it. We found what's causing it. She has a freaking tumor on her left adrenal gland. What do we do as surgeons? We remove it. When in doubt, take it out. Right? When in doubt, take it out, bro. That's what we're gonna do. And all that metabolic shit, you know, all that metabolic shit. Let's go refer this patient to Psychen. Psychen, Dr. Psychen, I got a patient for you here. This patient is freaking has a lot of metabolic shit going on. Yeah, you can deal with this. I'm just gonna go do my laparoscopy. Just give me a clearance and I'm gonna do the laparoscopic adrenalectomy. You can go handle all that metabolic shit. I'm not gonna do that. You do it for me. Okay. I don't know. Let's see how bad I did this one. Let's see how bad I did here. Oh, 71! 71! I don't think it's that bad. A lot of people got 100% though. Freaking heck. These people who got 100% probably have seen a lot of adrenal cases. A lot of people get a lot of adrenal cases. Alright. Okay, let's see what... Oh, I was thinking about doing this early morning ACTH, but then when I saw that there's a freaking... When I saw that there was a mass, when I saw the MRI, and I'm like, oh, there's a mass. There's already a mass. Okay, now we know what... There's a mass. Let's take it out. Let's take it out. I don't need to do this. What do you mean? I just found out there's a freaking tumor. Alright, let's read about this, bro. Because I need to know more. Oh. Middle-aged woman has presented with oligomenorrhea for 2 years. The above findings could be innocuous. The combination of obesity and metabolic syndrome is not uncommon, and her menstrual irregularities might be due to the perimenopause. That said, a 30-kilogram weight gain over 2 years is still concerning and should prompt further evaluation. When her family history is taken into account, the possibility of polycystic ovarian syndrome, which is now polycystic metabolic, polyendocrine metabolic ovarian syndrome. Yeah, PMOS. Rears its head. So they usually tend to have a longer history of menstrual abnormalities, and they also tend to present at a younger age. Yeah. Hypothyroidism is another possibility, but is excluded by the normal... Yeah, she had a normal thyroid blood test. Hyperprolactinemia. Yeah, she had a normal serum prolactin. Acromegaly and Cushing's syndrome are two other differentials. The normal growth hormone levels exclude the former. However, an overnight exomethasone suppression is positive, suggesting at hypercortisolism. A repeat test is also positive. A positive DST should be confirmed by a different test. 24-hour urinary free cortisol. Yeah, this was normal. Possibility of subclinical Cushing's syndrome should be considered now. SCS is a state of subtle cortisol excess. Such patients do not manifest the standard Cushingoid phenotype, and instead show non-specific features such as obesity and metabolic syndrome. Furthermore, while a normal DST result is often present, UFC levels tend to be normal. This is because the latter is not of sufficient sensitivity to detect minor increases in cortisol levels. An early morning ACTH assay is a good next step. Studies have shown that ACTH levels are usually low in individuals with SCS. This is because the hypercortisolism is independent of ACTH secretion. Here, this turns out to be positive, indicating that an ACTH-independent source of cortisol is indeed present. Imaging studies are an essential next step. Yeah, that's why I got a tumor in the adrenals. While there is controversy on how to best manage SCS, studies have shown that its metabolic complications can be cured, or at least markedly improved by adrenalectin. Laparoscopic resection is preferred over an open approach. See? See? There's a tumor! Take it out! Take out the tumor! Basically, you just needed to confirm for any primary versus secondary adrenal origin, but it's weird since the scan showed mass, but I guess they just wanted it. Yeah, I guess, it's okay. I'm a surgeon! I'm like, oh, hey, let's go for an MRI. Aha! Tumor in the MRI, we're taking it out. That's it, that was my thinking, bro. There's a tumor! My bukol! My bukol! There's a tumor in there. Therefore, we're gonna do surgery. Okay. Dexamethasone suppression test is considered the best screening tool for subclinical Cushing syndrome. Yeah, alright. Noted. Alright. I got 70%, 71. That's not bad. Okay. Bro, there's only 5 cases, general surgery cases, so I can't look at the rest because they're behind a paywall. If I remember correctly, I mean a lot of these weren't behind a paywall. All right, stuck. Let's see this one. Look at this. Stuck. A 52-year-old woman presents with worsening intermittent burning chest pain for 1 year. The pain does not radiate and is not exacerbated by exertion or lying down. Her primary care physician prescribed a 2-week course of omeprazole 1 month ago, but her symptoms were unchanged. Careful questioning reveals a mild dysphagia to both solids and liquids for the last 6 months, together with some episodes of saliva regurgitation while down. Oh, she has GERD. GERD? Wait. This feeling is worse in her upper chest. She also lost 5 kilograms of weight during the same time period. Her medical history is only significant for uncomplicated mild hypertension for 4 years. This is well controlled on amlodipine, 10 milligrams daily. She does not smoke and only drinks socially. Full blood count, 12 lead ECGs, and an exercise stress test have been ordered recently. All normal. Okay. Burning chest pain. So, yeah, she has regurgitation going on. Okay, I am thinking GERD. I'm thinking GERD. GERD. Gastroesophageal reflux disease. Let's see. She's stable. I'm thinking something to do esophageal, something to do with either the stomach or the esophagus. But I'm thinking GERD. What the heck is this PE, man? The PE doesn't give me anything. Walang nakita sa PE. At least we ruled out heart disease because she had like she has heartburn, chest pain. Alright, let's see. Mild dysphagia to both solids and liquids. Oh, wait. Both solids and liquids, though. That means she's unable to swallow. I mean, in GERD, you should be able to swallow. So, is there no? There's no mass either. I don't think there's a mass there because know what this is. Okay, we'll see. Alright, let's go. Let's explore. Okay, what do we have here? Upper endoscopy. Oh, manometry. Okay, manometry. There is impaired relaxation of the lower esophageal sphincter during deglutition. Deglutition means to end swallowing, guys. Alright? The basal esophageal pressure is 62. Oh! There is Oh, this is achalasia. There's peristalsis in the distal. This is achalasia, girl. This is achalasia. This is achalasia. I am 90% sure this is achalasia. Okay, let's endoscopy. The esophagus appears normal. Okay, there's gastroesophageal junction is difficult to traverse and only opens after multiple attempts. This is achalasia, bro. Do I need to do other tests for this? I mean, CT scan? I don't think I need to do a CT scan, though. Barium swallow. I don't think you need a barium swallow for this. Okay, yeah, I think it's achalasia. What is it? You know, achalasia, this is another one. This is another one that I don't see. Another one I don't see in hospital during my residency. I never ran into a patient with achalasia. I think probably because by the time these patients with achalasia, they stop at the GI. If the gastroenterologists probably get a patient like this, it doesn't they don't end up in surgery. Alright. Do I need to do a CT scan? I don't think I need to, right? Because that was it already. And that's the only possible freaking cause of whatever she has. Okay. So for achalasia, no, we don't do this. I am a surgeon, so we do a peroral endoscopic myotomy. I am a surgeon. We do procedures. Esophagectomy is overkill, bro. So imagine doing an esophagectomy for an achalasia. That is overkill. I think. Wait, how long has she been having this? She's been having this for 1 year. Wait, 2 weeks. Mild dysphagia is like that. Okay, yeah, she's been having it for a year. Yeah. Nabubulol na si Doc. Nabubulol. Peroral endoscopic myotomy. Botulinum toxin. The heck, my Botox pa. I don't need to do Botox for achalasia. I know myotomy is one. Especially if severe. I know that they also do. Wait. There's another procedure. Yeah, I think. Oh, no, wait, no. I think it's just myotomy. I was thinking about funduplication, but no, I don't think you do funduplication for that. I don't think you do funduplication for achalasia. It's myotomy. Botox. Botox sounds, but I think they do Botox. Wait. Heller's myotomy is, I think, yeah, that's one choice, but it's not here in the choices. I think it's it's based on these choices. Definitely a myotomy has to be done, but since Hellers is not here, we do the peroral endoscopic myotomy. Calcium channel blockers. Actually, yeah, I'm thinking. Wait, how old is she? She is suitable for surgery. Wait, yeah, we can give. Do we give calcium channel blockers to this if they're already gonna undergo surgery? And Botox. Botox, I'm thinking, is for those who can't undergo surgery. Do I? I don't know. Yeah, I think you can give, but you know what I'm thinking? You know what? You know why I'm overthinking this? It's because if meds don't work, you have the next thing you have to do is surgery. So in this with this person, this patient who's been having this for a year, she's been having this problem a year. It's like, okay, I know that the definitive treatment is myotomy. Yeah. But then I also know that I think Botox can be given. I feel like Botox can be given, but I don't know if it should be like in tandem with myotomy. Or do I choose this because it's a choice? I think Botox. All right, let's just choose all three. This one is way too. This is overkill. I think. Yeah, I think that's right. Do we need to? Doctor Doldoc. What? All right, I think this is it. We don't need CT. I'm not sure about barium swallow because we already have this. Like, this is it already. Do I need a barium? Okay. Anyway, okay, let's go. Let's see how I did. Let's see how bad or good I did. 58. Where did I go wrong? I think is it barium? Did we have to do a I think one of them is barium swallow. Okay, let's see where we got for. What? You do a CT scan? And a barium swallow? No, I'm more surprised about the CT scan. Is this just to rule out tumors? But you already did a EGD, man. EGD didn't see anything. What the heck? Calcium channel blockers. You're not supposed to give. And okay, then I was right. It's just myotomy. You don't do anything else. It's myotomy. Defensive medicine it is. I know, right? You do. Okay, so it's really just myotomy here. You don't do anything else. Okay. But I am surprised about especially this CT scan. I'm like, I already saw the freaking thing. Oh well, let me see. Okay. Chronic chest pain. She's already seen by her primary care physician who has attempted to exclude anginal pain via ECGs and exercise. Yeah, okay. Treated her with a course of proton pump inhibitors with little success. At first, the burning nature of her pain is most suggestive of death. This is exactly what I thought. Is it GERD? However, some response to PPI would have been expected. Close questioning reveals a key clue. Recent onset dysphagia to both solids and liquids. And regurgitation, so favors an esophageal motility disorder. Achalasia immediately rises to mind. Her presentation is characteristic. However, diffuse esophageal spasm can also present in this manner, as can pseudoachalasia. I forgot. Yeah, it is actually US based. That's why some things are like what? It is actually. That's why I do everything. Apparently in the US, do everything. Further evaluation is mandatory. Okay, endoscopy is a very good first test. Yeah, okay. No esophageal or gastric lesions. However, the gastroesophageal junction is difficult to traverse. Esophageal manometry should follow, which I did this one first, and then EGD. So we found a peristalsis and incomplete lower esophageal sphincter relaxation. So basically, the sphincter on her esophagus, the lower part of the esophagus, wasn't relaxing, which explains why she couldn't swallow. Because when you swallow, when you swallow, your esophagus, the sphincter in the lower part of your esophagus is supposed to relax so that the food goes into the stomach. But in her case, when she swallows, it doesn't relax, so she regurgitates whatever she eats or drinks. So, barium swallow is also advisable. Findings seen here support the diagnosis and provide an objective measurement to the degree of esophageal emptying. Okay. Age of the patient, short duration of dysphagia, and difficulty traversing the gastroesophageal junction raise the possibility of a pseudoachalasia, which is caused by primary or metastatic neoplasms at the level of the cardia. Cardia meaning the upper part of the stomach. Oh, so that's the rationale for the CT scan, just to rule out freaking neoplasm, but then you had an EGD already. Wait, but you had an EGD. This is weird. I would expect that EGD is more accurate in finding like tumors. Yeah, tumors in the stomach, or because you directly, it's like direct visualization. Okay. It's freaking weird. Okay, whatever. Okay, high resolution manometry findings suggest type 3 achalasia, for which a peroral endoscopy myotomy is the preferred management. Pneumatic dilation is an option to patients who don't improve after peroral endoscopic myotomy. Esophagectomy is mainly an option in late-stage achalasia. Oh, mega esophagus formation. Yo. Botox. Okay, Botox and calcium channel inhibitors have only limited efficacy. Okay. So, yeah, I was right. These are for patients who are not candidates for surgery. So, she was a candidate for surgery. Yeah. Alright. Oh, here we go. Types of achalasia. Type 1, classic achalasia. There is no significant change in esophageal pressurization. Type 2, there is simultaneous pressurization that spans the entire length of the esophagus. Type 3, spastic achalasia. There is premature and often looming obliterating contractions or spasms. Okay. Oh, this is long. The discussion's pretty long. Take-home messages. Early stage achalasia is easily misdiagnosed as GERD and should be considered in persons with supposed GERD who fail to respond to an adequate course of proton pump inhibitors. Esophageal manometry is the gold standard. This is why this was the first one I checked. Endoscopy and barium swallow. Okay, supporting roles but are not a replacement. Okay. Hello, human. Hello. Alright. Okay. And that is... Wait, that's it? I can't see the others? Okay, hold on. I think we can look at other surgery stuff. Let's see. Can I go by, subspecialties? Maybe we can, general surgery had, like, only... Wait. 66. There's 66, but I can only access a few. Let's see. Is there another, Maybe there's a subspecialty that we can look at. Maybe. Ooh, trauma! Let's go to trauma surgery. Let's check this out. Ugh! Adam 2. There's no Adam 1. Rugby collapse. Wait. That's it? This is the only... Okay, let's look at this. Let's look at trauma. Oh, not long ago you treated 15-year-old high schooler and rugby team captain Adam McGlynn. They even have names now. For infectious mononucleosis. You cleared him to attend school, but asked that he avoid contact sports for 4 weeks. Unfortunately, boys will be boys. Just 3 weeks later, Adam is brought to the ED, accompanied by his coach. Apparently, he started rugby practice yesterday, after informing his coach that it was safe for him to practice now. Wow. Bro, this kid. Yo, I said 4 weeks. I said 4 weeks. And you're like, hey, it's 3 weeks. 1 week early is nothing. Freaking, this is what happens to you. Oh, this is long, yo. The coach says that Adam collapsed mid-game 20 minutes ago. He complained of dyspnea and pain over the left side of his abdomen and was rushed to the hospital. Adam describes a throbbing, continuous 5/10 pain in the left flank that radiates to the mid-epigastrium. He also tells you he feels sharp pain on his left shoulder. Oh my god, what happened to you? You recall that he has no chronic illnesses, is not on any medications, is fully immunized, has no allergies, and does not drink alcohol or take drugs. On examination, his temperature is 37.6, blood pressure is 100/70, pulse is 80, and respiratory rate is 25. His oxygen is 95%. No external injuries are present. There is no evidence of rib or spinal fractures on deeper palpation. There is localized tenderness just below the left costal margin. No other untoward findings are present. You obtain IV access and order a panel of investigations. A short while later, your results are in front of you. Okay. Hemoglobin is a bit low. The hemoglobin is a bit low. Hematocrit. Platelet is a little low. Ayo! AST, ALT. Wait, where is his ano? His pain is on the left or on the right? Left. Oh, it's on the left. Okay, he's on the left. Alright. The hell is going on here? LD, okay, what's this? BON, Crea, okay, everything else is okay. Except some elevation on the AST, ALT. Ugh, okay. He has no injuries, okay. Well, he was playing rugby. Rugby is like football, right? I don't... Am I right? Rugby is like a tackling game, tackling sport. If I remember correctly, it's like American football. Am I right? Is that what rugby is? Oh, it's it's a tackling. So most probably has like blunt injury or something. Was there yung sinisingot? Ibang rugby yan! Ibang klaseng rugby yan, gago! Ibang klaseng rugby. Okay. I'm thinking of a blunt abdominal injury here. Let me see. Pain is left flank. radiating to the mid-epigastrium. And sharp pain on... Okay, so it's all on the left. Alright. Whoa, what is this? Bedside organ assessment with sonography after... Yo, what is this one? I only know fast. What is boast? Whoa. Fast. I know fast. I don't know what boast is, yo. The sonographer on call performs a scan. She vaguely reports splenic enlargement and free perisplenic fluid. You realize you should have ordered a CT scan in the first place. What the hell is this? Yo, I'm in the Philippines, man. I'm in the Philippines. The first thing we order is a fast. The first thing we order is a fast, bro, for trauma. Okay. Okay, CT scan. But I need to look this up though. I don't know what a boast is. The contrast-enhanced CT scan shows a subcapsular hematoma of the spleen. Oh, and he was right. It was thinking of splenic injury, extending to 25% of the surface area, and a splenic laceration that is 2 centimeters in depth. There is no extravasation of contrast. The hilar vessels are not involved. No other intra-abdominal injuries are present. The splenic injury is radiologically evaluated as grade 2. Okay. Oh, grade 2. We will manage you conservatively. So I was right. So rugby is a sport, a tackling sport, right? Where you like hit each other. So I was thinking he probably got hit hard enough and injured his spleen. Rugby is adult version of American football. American football is when you give rugby players training wheels and padding. Oh god, okay. Alright, so... we manage conservatively. I go manage conservatively. There we go. You decide to admit Adam to the critical care unit and manage him supportively there. In the meantime, Adam's mother and very senior family physician, Dr. McGlynn, arrives. She nods in agreement. Kaki! Yung nanay niya, doktor! Guys, nakaka-stress yan. Imagine you have a patient like this. The patient is brought to you, and then you're managing it, and then their parent of this patient comes, and then apparently doktor din. Minsan nakaka-stress pag ganun. Nakaka-stress because sometimes they will like, they will be like, oh, they will start inputting their opinions and stuff like, I think nurses would feel the same way. You're getting silently judged, yeah. I think nurses would feel the same way. Like, I've seen skits of these, like, a nurse is taking care of a patient, and then the patient has a relative who's also a nurse, and then yung relative na nurse, the nurse relative just starts saying all these things, and like, I don't know, suggesting and saying, oh, this should be done, oh, this, and I know it pisses off the nurse. May kapamilya na nga ang doktor humingi pa ng second opinion. Alright. Anyway, let's continue. Aba. Bro, nakangiti na siya dati. Sa unang picture, hindi siya nakangiti. O ha? Yung tatay lang yun. Ay, hindi. Yung coach niya. Yung coach niya, yung nakangiti. Siya hindi. After that, nakangiti siya. Yung nanay, hindi. A few days later, Adam has improved markedly. There's no abdominal pain or tenderness. His hemoglobin and hematocrit values are stable, and he feels completely fine. Subsequently, after a discussion with Dr. McGlynn, you decide that Adam can be discharged home. She promises to restrict his activities and to keep close watch out for red flag symptoms of delayed splenic bleeding. You also make arrangements for outpatient sonographic follow-up. As Adam and his mother leave the hospital, you breathe a sigh of contentment. Hopefully, Adam should be fine this time. Or will he be? Find out in the final scenario. Gago, may Adam 3. Gago, series pala to. Parang episode lang. Gagi, TV series pala to eh. Bro, Adam 1, Adam 2, and Adam 3. 50%? Really? Oh, because I did a fast. I got 50% because I did a fast first. But see, you see the thing with this? So, in Philippine setting, okay, in trauma, the first thing we do always is fast, actually. Especially here in the Philippines. Why? Because an ultrasound is cheaper. Much, much cheaper than a CT scan. So one of the first things we do actually is a fast. Because it's the ultrasound is right there. And as surgeons, we sometimes do the ultrasounds ourselves. We do the ultrasounds ourselves just to see. And then, if the patient is stable, we do a CT scan. So, I have no idea what this one is. Bedside organ assessment with sonography after trauma. What is this? Like, what is this? Is this an actual thing, or is this a trick? Is this a trick answer? I'm gonna look it up right now. Wait, hold on. I think this is... I'm like, what the hell is boast? I think it's a non-existent answer. I think it's just to throw you off. Bedside organ assessment. I've never heard of I think it doesn't exist. I think this is just to throw you off. I think this choice here, the boast, is to throw you off. I mean, the fact that it... Actually, when you think about it, it's called boast. Meaning, nagyayabang ka. Sonography. Okay. Yeah, I just looked it up. Yeah. It's fast. It's just it's to throw you off. The proper term is fast, not the proper term is fast. This is just to throw you off. Okay. Alright, view analysis. Let's look at this. Decision 1. Oh, here we go. Decision 1. Perform fast. Bad. Bad choice. Are you kidding me? Decision 1. Adam is hemodynamically stable, therefore contrast CT scan is the gold standard for evaluating solid air organ injury in a patient with blunt abdominal trauma. Fast is primarily used in unstable patients to detect free fluid and is less sensitive for grading specific to organ injuries. Bose is also less... Oh, it is a thing. Bose is also less reliable in CT, especially for lower grade injuries. I have never seen this. Really, CT scan. Iba to! You know, iba to sa Pilipinas. In the Philippines, we do fast. So I guess in the US, they go straight to CT scan. Alright, this one I did right, yeah. If it's a splenic injury, and it's not actively bleeding, and it's not, the injury is not as bad, you don't operate. You can treat splenic injuries conservatively. Like, the only time you operate on a splenic injury is if it's actively bleeding. You can either repair the vessels, or repair it, or if the spleen is shattered, or like really yung sabog na talaga, then you remove it. Here we go. Non-operative management of blunt splenic injury. Yeah. Alright. And I can't look at all this. Bro. I can't. Traumas. Okay, fine. Let's see what else we can look at. Oh, let's do urology. Let's see. Malay mo merong bulitas case dito. Urology, elevating. Oh, let's try urology. Let's try my urology. Let's see if I can do urology, yo. Okay. A 48-year-old man presents with intermittent fever for 1 week. The fever was low-grade initially, but became high-grade yesterday. He has had a dull ache in the upper left abdomen for the same duration. No other symptoms are present. His medical history is significant for type 2 diabetes for 8 years, with poor control, limited dietary compliance, and only occasional follow-up. Whether he has any complications of diabetes is undocumented. He experienced an episode of cystitis 1 month ago. This was the first urinary tract infection in his life. This resolved with antibiotic therapy. He defaulted on follow-up and has not been evaluated for abnormalities in the urinary tract. He is currently on metformin 850 milligrams daily and glycoside 30 milligrams daily. He has no allergies. He drinks socially and does not smoke. There is no history of recreational drug abuse. Basic investigations show a leukocyte count of 16. Oh, it's high, okay. 90% neutrophils and capillary blood sugar of 225. Ang taas, be. Okay. Pilipinas lang ata gumagamit. Oh, you mean the fast? Not really. No. The ultrasound is used globally. That is a global thing. It's just that I think here in the Philippines it's used more because in our setting, if you don't have access to CT scan, or sometimes patients can't afford CT scan, you gotta use the ultrasound, which is, it's not as accurate as a CT scan, but it's much cheaper and it'll at least give you a clue about what's happening inside the abdomen. So yeah. Okay, so let's see. This guy has had fever with the pain on the left upper abdomen. Okay. He had UTI for the first time ever, and he treated it with antibiotics. So, on physical examination, heart, no abnormalities. Okay. Lungs, reduced air entry into the left lung base. Oh, he has something going on his left lung. Okay. Vital signs stable. General examination, here we go. Abdomen, mild tenderness of the left hypochondrium and lumbar region. Renal anger he has signs of renal anger, tenderness, no guarding region. Okay. Why does a reduced air entry in the left lung? He has pneumonia or some shit? Okay. I think he has a stone. Pyelonephritis? Pwede rin. Wait, does he have fever? Oh yeah, he has been having fever. Wait, let me see. Leukocyte. Oh yeah, he has 16. There's no urinalysis, is there? They didn't do a urinalysis here. He has infection. Yeah, it can be a pyelonephritis. Yes. Maybe he has a stone. There's no imaging yet. Okay, let's see. There we go, urinalysis. That's what I was looking for. Urinalysis. Urinalysis is unremarkable. Ultrasound of the abdomen and pelvis. I think I'll do CT stonogram, bro. CT scan. CT. Here we go. There is a large, thick-walled unilocular collection surrounding the left kidney. There is no extension into the kidney or the surrounding structures. Gerota's fascia is thickened in the posterior aspect. There are no calculi. There is a small left-sided pleural effusion. I'm guessing that one is less reactive to whatever's happening in his kidney, yo. Alright, so, yeah, I think it's pyelonephritis. Doesn't tell you how much there is though. There's no measurement. Okay. Urine blood culture. He has nothing in his urine. Blood culture? I don't think. Do we need blood culture? Hindi naman siguro, no? He's not septic. Okay. Ultrasound. We already have this. Oh wait, ultrasound is what will. No wait, but in the CT scan, they should be able to. They should be able to tell you how much is in there. Anyway, okay. Identify actions. IV antibiotics, yes. Intercostal tube. I don't think you need that. Small left-sided pleural effusion. US base, just do all of it. Should I do an ultrasound? I don't see the logic of doing urine and blood culture though. An ultrasound, like, wait, I already have a CT scan though. Like, the CT scan should tell you everything already. Intercostal tube for a minimal, where is it? It says small left-sided pleural effusion. Tight glycemic control. Yeah, control your diabetes, bro. Percutaneous drainage. We can do a percutaneous drainage. There's a unilocular collection, so there's an abscess going on. Okay, let's drain it. I'm a surgeon. I'm a surgeon. We gotta drain that. And the pleural effusion, I think that one can go. If it's tiny, we don't need to really. We don't really need to do much to this. I know you don't. I know if it's a small pleural effusion, you don't need to like do anything to that. All right, let's see how we did. Ugh, 93. I swear to God, if they told me that I have to do an ultrasound, this is bullshit. This is bullshit. Tapos yung pala kailangan lagyan ng tubo yung lungs niya, buwisit. Alright, let's see. Oh, look, you do a urine and blood culture. Why though? Wait, why though? Okay, urinalysis, yeah. Could this be a perinephric abscess? Although that negative urinalysis would seem to argue against that, there may indeed not be signs of any urinary tract infection if the abscess has no communication with the collecting system. Even with no pyuria, however, it is prudent to perform cultures in a patient with a possible complicated urinary tract infection, especially if recurrent. Regardless of whether the ultrasound is performed, yeah, okay. So you're telling me that, yeah, because his pee doesn't have any signs of infection doesn't mean that because it's perinephric. I was thinking he's not septic or anything. Like, he doesn't need to have blood culture. Yo, what? Yeah, because of the presence of fever and high neutrophil count, thus requiring blood CS. I don't know why. God, okay. I was thinking maybe they want a blood culture, but then the whole how the patient look, he's not septic, he doesn't look like he needs it. Oh well. America. Yo, they do a lot. Of what the heck is this? Look at this case, man. The name of this case is Stoned. And then it's a dude looking at you like, yo, look at this. Look at this case, yo. Where is it? And the title is Stoned. The art they use. Is this like an actual art? Or this is not... I hope it's not AI, but this is funny. It's freaking funny. Alright. Riz. Alright, let's see. Mm. What other surgical uh what other surgical specialty can we try? There's only one euro case. Surgical oncology. Okay, let's try this. Antonio 1. Okay, let's see if I can do this one. Antonio 1, under pressure. The endocrinology clinic can be quite challenging at times, but you've had a quiet day so far. The door opens once more and your next patient comes in. 32-year-old Antonio, who has been referred by his primary care physician. You introduce yourself, shake hands, and ask him to take a seat. You peruse the referral letter. It states that Antonio's blood pressure was found to be 140/90 at a routine health checkup. His blood pressure on the following day was 160/95. Antonio was asymptomatic with unremarkable medical and family histories. He was not on any medications and denied using recreational drugs. The examination was unremarkable. A full blood count, serum sodium, potassium, and calcium levels, fasting plasma glucose, renal profile, liver profile, ECG, X-ray were all normal. Thyroid profile, serum parathyroid hormone levels, and an ultrasound scan of the neck were also normal. However, abdominal ultrasound revealed a 3.5 by 5 cm mass above the right kidney. The primary care physician suspected this might be a pheochromocytoma and referred Antonio to pheochromocytoma. Alright. What the heck? He's looking at me like this first, and then he suddenly looks at me like this with raised eyebrows. You put the referral letter down, take Antonio's history, and perform an examination. However, you fail to elicit any new findings. You also peruse his investigation results and confirm the primary care physician's conclusions. So he has pheochromocytoma. Which of the following will you order? Oh, acting on the assumption that this might be indeed a pheochromocytoma. You ponder what to do next. So, this is another adrenal tumor, the pheochromocytoma. Alright. We are going to... What is the next thing we will do? Oh my god. Again, it's an adrenal case, so I haven't really had much adrenal cases. Alright, we will do a 24-hour... Should we do this? Or should I do a percutaneous biopsy or plasma? Which of the following? You only do one of it though. You can only choose one. Just do it all. I can't. You can only choose one. I think one of these only. Plasma-free metanephrine or normetanephrine levels. 24-hour urine metanephrine or catecholamines. This is a biopsy. I don't think you need to biopsy this for now. I don't think biopsy is the right one. Or is it? We have to confirm that it's a pheochromocytoma. Wait, let's see. Gotta head out. Was lurking but had a great time. Thanks for walking us through these. Okay, what's this? Key wielder Sara. Thank you for stopping by. Oh, it's 11:35. Okay, this is gonna be the last one. I will see how, maybe we can do maybe next time we can do this. But it'll be like, I will unlock the rest of the questions. We'll see if I can do that. Alright, I will... let's go for plasma-free metanephrine. I'll go for this. You decide to order free metanephrine and normetanephrine levels. After writing out the order, you ask Antonio to come back later on in the week once results are available. Wow, it takes a week to get the results? Several days later, Antonio's in front of you. You peruse the investigation results as you expected. Both are elevated. Okay. You explain... So it is pheochromocytoma, right? Now that you have biochemical evidence of a pheochromocytoma, you realize that you need to stage the tumor. Oh, stage! That means we use imaging. We will use imaging. Yeah. Alright. Oh! A CT scan or an MRI? or this? What? Bro! Bro! You can only choose one. Okay. If I was living in America, which imaging will I choose? Let's see. Should I do MRI? I think MRI is better. Yeah, I think MRI is better for adrenals, right? Okay. Scintigraphy. I will go for an MRI. Okay, here we go. Order an MRI of the head, neck. Oh my god, everything. Gagi, MRI ng buong katawan. Okay. You called up the radiology department and scheduled a date. Once more, you bid Antonio goodbye, scheduling a follow-up or for when results are available. A couple days later, Antonio's in front of you once more. You peruse the MRI report. T2 weighted images confirm a hyper-intense right-sided adrenal mass measuring 3.5 by 5 cm. There is no evidence of invasion to adjacent structures or metastasis. No other abnormalities are present. Ah, okay, so... Now that all the irrelevant investigation results are in, you have a frank discussion with Antonio about his further management. Yeah, he's gonna have a surgery. You explain that surgery is likely to be curative and that you'd like to refer him to the endocrine surgery unit for this. Antonio looks grim but nods in understanding. He asks for a few days to discuss with his family and takes his leave. Gagi! Ang pogi naman ng doktor! The medical students who've been... Med student ba to? Med student? Ang pogi mo naman. Nakangiti! Oy! Pogi! The medical students who've been on rotation with you for the past several days are intrigued with how Antonio's case is unfolding. One of them asks the questions. Will you be assessing him for familial syndrome, doctor? How do you respond? Familial? Yeah, Actually, yeah, right? Does he have any others? Yung ano, diba? Anyan yung, I think, if I remember correctly, yung mga MEN. Men 2. I mean, wait. He does have, what are his other symptoms again? May high blood siya, tsaka... Does he have any... Ay, hindi, wala naman. Yeah. Let's get yes. Yes! You are about to reply in the affirmative, but then feel uneasy. Okay, so no? I was thinking maybe he has men too. Okay, so it should be no. I guess it's only if he's having other symptoms. Like he only has hypertension. All right. There are three main familial syndromes associated with pheochromocytoma: von Hippel-Lindau syndrome. Here we go. See, men too. Multiple endocrine neoplasia 2, and type 1 neurofibromatosis. However, the clinical, biochemical, and imaging finding. Yeah, okay, I was right. That's what I was thinking. He has no other. No. All right. So it's just like he just has pheochromocytoma. That's it. A couple of days later, Antonio's back in front of you. I've spoken to my family doctor, and I'd like to proceed with the operation, he says. You proceed to write out a referral to the endocrine surgery unit and call up your colleague. Subsequently, Antonio thanks you and takes his leave. Follow the next chapter of his story, and Antonio 2 under control. This is interesting because is American medicine like this? He went through 2 types of referrals though, because like he had a referral. No, because here you're acting as an endocrine, an IM. So primary care referred to endocrinology, which you are acting as here, and then you're gonna refer to surgery. Okay. I got 67. I'm like on the average. Alright. Good, bad. Okay. So you only do you assess familial syndrome only when there's other symptoms. Yeah. Alright. This one, oh no, I think this is the Paget's disease, right? This is the Paget's disease. We did this one already. There's so many though. Thoracic surgery? I don't think I'm good at thoracic surgery actually. I'm not good with this one. Pediatric surgery? Is there anything I'm not good at pediatric surgery either. Even ortho. I'm not a bone. I'm not. Yeah, that's it. Basically. Alright. How do we... Let's see how much is the subscriptions for this? Because I can unlock the rest of the cases. I just have to pay though. I think they're behind a paywall. Let's see how much. Start your 7-day free trial. Oh, it doesn't tell you how much though. How much? We can do this again. I'll see if if I do this again, I'll do the 7-day free trial and then close it. Oh, it's taken a while to load. What? Alright. I think we're okay now. We're good. Oh. Oh, I got disconnected. Oh, hello. Am I back? I got disconnected for a bit. Okay, I got disconnected for a bit. Am I back? Am I back, chat? Am I back, chat? Because I got disconnected for a little while. Okay. Oh, wait, guys, wait, hold on. Remember we did Antonio 1? And we can do Antonio 2 now. Hold on, wait. Let's go back. We're gonna go back. We're going back. We didn't do Antonio 2. We can do Antonio 2 now. Here we go. We are now the surgeon. We are now the surgeon, guys. Antonio too. Antonio too. Okay. Several days ago, your colleague in the endocrinology clinic diagnosed 38-year-old Antonio with a pheochromocytoma after he presented with an unexplained clinically silent hypertension. Imaging studies revealed a 3.5 by 5 cm right-sided adrenal mass without local invasion or metastasis. Subsequently, Antonio was referred to the endocrine surgery unit where you work for surgical excision of the tumor. He is now in front of you. You put down Antonio's records and discuss the management plan. You explain that you cannot operate on him immediately and that you will need to pre-medicate him for a while first. I guess we gotta lower the hypertension, yeah? Antonio is still completely asymptomatic. His current blood pressure is, there we go, is 160 over 90. He is not on any medications currently. Which of the following will you do now? I will refer to him to cardiopulmonary, to cardiology for clearance. Refer to IM for clearance. For CP clearance. I-control niya yung BP nito. Control yung BP nito. What's this? How much did I miss? Nakapasok ako sa stream kanina lang 10 p.m. Oh, hello, Kyosha. Antonio the Mogger. Nasa puso ka namin, Doc Parate. Di ka mawawala. Wow. Wow. Edi wow. Kainis kayo. Alright. Which of the following will you do now? Start phenoxybenzamin and propranolol together. Start phenoxybenzamin and add propranolol after 2 to 4 days. Start propranolol and add Oh my god, I don't know. Ito yung di ko alam. I-refer ko kasi sa IM. Bruh. Okay. Let's see. I am na dapat kaya nga eh. I am na dapat dito eh. Refer to Syken. Syken, go do this. I'm here to operate. I'm not here to treat his hypertension. I actually don't know how to do this one. Start phenoxybenzam, benzamin, propranolol. Do you start them together or do you not? Does it have to follow like a certain regimen? The heck? Okay, chat, what do you guys think? Because this one, I have no idea. I don't know. I'm not good with adrenals, to be honest. We rarely see adrenal cases, too. What do you think, chat? I'm thinking, what of the 2 to 4 days? But I don't know if you start with phenoxybenzamin or propranolol. I'm gonna say... I am going to say... Phenoxy first. I was thinking, actually, yeah, I was thinking phenoxybenzamin first and then propranolol next. Though I'm just guessing. I'm just guessing. I'm just guessing. Okay, let's pick one. Let's pick this. Let's see what happens. They don't tell... Oh! That's it? They don't tell you what happens? Is my patient gonna die? Wait, hold on. Hold on. 7 days after his initial visit, Antonio is back in front of you. He complains of feeling lightheaded when standing up, especially if he's been seated for a while. Okay. You find that his blood pressure is 120/80 when seated and 100/72 when standing up. Blood pressures in both arms are equal. His other vital signs are within normal parameters. Okay, so he has orthostatic hypotension. Okay. What the hell is this? What the heck is this, bro? I thought I'm a surgeon. Why are we doing this? Akala ko surgeon ako, but ako nag-IM nag-IM stuff ako dito. What the fuck is this? Advise him to increase his intake of salt and fluids. No, I don't think that's... Why are we doing IM? Yeah, exactly. Why are we doing IM things here? What is this? Omit the phenoxybenzamine and start doxazosine. Omit phenoxybenzamine and propranolol and start nifedipine. Advise him to increase salt and fluids. Bro, why are we doing this? You think he has to hydrate? He has to hydrate. Well, to be fair, his BP isn't that bad. I think he just has, yeah, right. To be fair, yeah, there's nothing else that's wrong with him. All right, I don't think we need to change anything. Okay, sige. You explain to Antonio that his symptoms are most likely due to phenoxybenzamine and that increasing his salt and fluid intake should result in the resolution. Alright. 2 weeks pass. Antonio's blood pressure is well controlled now. The anesthetic team gives you the green light to proceed. Subsequently, you admit him to your ward and prepare him for surgery on the following day. Bakit ba kasi walang IM? Gagi yung tsura niya. Oh, may med student pa. One of the medical students on rotation with you has a question. Will you be using regional or general anesthesia, doc? Oh, we'll use general. General anesthesia. Who's gonna do? Walang CP clearance. Ikaw yung mag-clear ng sarili mong pasyente, apparently. I don't know. General anesthesia. You explain that this is preferable in pheochromocytoma surgery as it is easier to handle potential intraoperative complications such as fluctuations in blood pressure and heart rates. Klaseng hospital yan. Walang IM. Oo nga. Yo! The following day, you operate on Antonio. The surgery is uneventful. Subsequently, he is transferred to an intensive care unit for close observation and monitoring. Around 30 minutes post-op, you enter the ICU for one last look at Antonio before going home. No sooner have you stepped in, though, that his condition suddenly deteriorates. Ala, bakit nangyari sa'yo, gago? Your critical care colleagues rush into action. Antonio's unresponsive. His pulse is 142 and his BPM and his blood pressure. What the fuck's going on, bro? What the hell's going on, bro? Ba't nag-toxic bigla? Okay, what did they... Okay, 30... It's 30 minutes post-op. Okay. What do you expect the critical care team to do? Administer a normal saline bolus or start noradrenaline fusion? King inang to! Is this due to sudden drop in actually probably napaka-ano naman yan? 30 minutes post-up, biglang ganun. Imagine that if I had to do a adrenalectomy, an adrenalectomy for this, and then he starts crashing like this. Post-op, Jesus Christ. Okay. Okay, what do you expect to clear? Okay, the first thing I would do here, actually, hydrate yung gagawin. What's this? Bolus. Yeah, the first thing I would do is bolus bago mag, ano, parang bolus bago mag, ano, diba? Bago mag noradrenaline. That's the first thing I will do. Like, freaking hydrate! Bomb this patient with fluids, yo. As you expected, your colleagues administer a fluid bolus. His Antonio's blood pressure increases almost immediately, stabilizing at 110/75. Jesus Christ, bro, you gave me a scare. Antonio, you gave me a scare. Nakangiti. Kagi, nakangiti to. A few days later, Antonio is stable and has recovered completely. You notice the look of gratitude and relief on his face when you mention the good news, and that you can consider discharging him as early as tomorrow. As you walk away, you reflect on the benefits of being a doctor. Not the easiest career for sure, but certainly one of the most gratifying. Tapos na, walang Antonio 3. We have finished the Antonio series. It's just 2 episodes. Nakangiti pa si Antonio. 100%, yo. 100%. And this is coming from someone who doesn't know much about freaking adrenals. We don't see adrenals that much at all. Si Antonio. Oh, here we go. I'm gonna see the phenoxybenzamine, a non-selective alpha adrenoreceptor blocker, is a drug most often used to control blood pressure. Once alpha blockade has been established, a beta adrenoreceptor blocker such as propranolol can then be commenced for heart rate control. Note that alpha blockade should always precede the beta blockade. Doing otherwise is risky. Unopposed alpha adrenoreceptor stimulation may precipitate a hypertensive crisis. Okay. Alright. Yun lang. I think we did everything else. I want to be able to do the others though. But, wala. Hindi ko magawa. Like this one, I want to do this. Oh, you can only see like the first, ano. Like this. A 71-year-old man presents with persistent lower back pain for 1.5 months. The pain is dull and aching in nature and does not radiate. There is no history of recent trauma. His comorbidities are well-controlled hypertension for 15 years and ischemic heart disease, for which coronary artery bypass grafting was performed 10 years ago. Full blood count and urinalysis were normal. PE looks normal. What the hell? And that's it. Yun lang. Persistent low back pain. Tapos PE normal. And then that's it. You can't see. Oh, is it? You can see the. Oh, we can't. Alright. And that's it. Voila. I can't see the others. Yeah. Alright. It is 12. After looking at Antonio. It is 12. Yeah, sakto tayo. Sakto. Alright, guys. Wala na naman yung chat. Where's the chat? The chat is gone again. Ayun. Salamat sa stream, dog. Yeah. Ibang klase ka, Antonio. I'll see if I can, I will look at, I'll look at how much the quiz thing is. Like, I as far as I know before, it wasn't behind a paywall. I'm surprised it's under a paywall now. I mean, it's behind a paywall now. I haven't really done this in quite a while. Let's see. I'm gonna look at. I know this is in mobile. Let's see if mobile if it's is it still like that? Is it also behind a paywall here? Oh. Yeah, it is. This used to not be behind a paywall. It is locked now. This used to be free. Now it's not. What the heck? Yo? They now want money. This is... Okay. Okay, anyway. Classic subscription-based moping. Yeah, this wasn't... They didn't have subscriptions before, now they do. I guess their thing got popular. I can probably use this to review for my exam, too. I will see. I will see how much it is first before I, and if it's worth it. Let's see if it's worth it. Alright, so upon guys, thank you for coming to my stream. My next stream is in Twitch tomorrow. Tomorrow night, my next stream will be on Twitch, and it's Friday, so let's see, let me look at oh wait, whoa, yo, hold on. Official update for our community. We are not shutting down Stream Elements. Oh! Yo, Stream Elements is not shutting down. That's good news, bro. I don't need to look for another bot. Yay! Oh my god, yay! That's good news. That is good news. Okay, I don't need to like search for another so I can still keep my stuff in that Tuli command will still be working, guys. Tuli command will still be working in Twitch. Okay, on Twitch I mean. Okay. I will only use Stream Elements as a bot. Yeah, it's my bot, and it's also for Stream Elements is also for my alerts, especially Tiltify. Stream Elements, as far as I know, Stream Elements is the only one where you can use Tiltify. So, yung mga, those the Dono streams, it's Stream Elements. Like Stream Elements is the best one so far that I've used. Like I used to use Streamlabs, but I moved out of Streamlabs, and Stream Elements was good. I tried Mix It Up for a while, but I preferred Stream Elements. So yeah. Stream Elements is like the best one so far for me. Stream Elements, yeah, Stream Elements is the tooling command. That's a Streamlabs alert. Yeah, I used to use Streamlabs, but if I remember correctly, I stepped away from Streamlabs before because of the Streamlabs had an issue like in early 2020s. I think it was in 2021 when was it 2021 or 2022 when they when that issue came out with Streamlabs. Anyway, so alright, Otsupon, my next stream, yeah, tomorrow Twitch will continue Claire Obscure Expedition 33, and Saturday Tekken 8 stream. Yes. Alright, so let's see, maybe is there anybody we can redirect to? Parang wala yata. Wala ba nagsistream ngayon? Let me see. Is there anybody we can redirect to right now? Parang wala. Wala nga. There's none. Okay, there is none that I can. Yeah, okay. We'll just end stream. Thank you for the super chat, Kyosha. Thank you. Otsupon, guys. I'll see you guys tomorrow on Twitch. Bye-bye. Good night.